involved in any diseases.
So fenestrations don't get affected?
Fenestration is the one that's the whole, right? You have to have fenestration affected, whether it's a negative, whether it's a charge barrier or size barrier. Fenestration is just a name for the pores. So anything affects around them will affect the pores. Whether it's a globulin or albumin, fenestration will be always affected. Only fenestration affected gives you all these leaks, if not the problem, right? So, but what causes the fenestration to be affected? If you see this diagram, the things around them will affect the fenestration. Okay, fenestration it sounds like a big structure. It is not a structure, it's just literally a pores. That's all it is. Okay, all right. So now you could see that's a compost. Now look at this on the side. I already mentioned this. There's a charge barrier and size barrier, folks. Okay. Now, whatever I tell you about this charge and the size, you could read it. It's the same thing. Okay. Why charge barrier and why size barrier? Okay. That's your filtration barrier. Is everybody clear here, folks? So that's important. Charge versus size barrier. All right. Now, any question for me before I move? No question. All right. So let's go here. Some terminologies. You do not have to memorize any equations or anything, folks. We have to understand this. There's three things, folks. Okay. Now, if you see here, the first one. Let's say here, in the same diagram I'm going to tell. Watch me carefully. If I tell I filtered 500 ml in here, but only 300 came out, excreted. What happened to the other 200? It's reabsorbed, isn't it, folks? That's all it is. That's what that line says. If the clearance is less, clearance means excretion. If the clearance is less than GFR, it tells you you reabsorbed. Is everybody clear, folks? Now, if I tell you on the other example, I filtered 500, I excreted 800. What happened? I secreted 300 into this. That's why 500 plus 300, I get 800. Is everybody clear, folks? So that tells you the clearance is more than GFR. That means there's a net secretions. Is that clear, folks? Okay. And the last one, I filtered 500 and I excreted 500. So filtered 5, excreted 5. No reabsorption, no secretion. It's the same amount you filtered, you are excreting. Okay, that tells you when the clearance equals GFR, that tells you no secretion or reabsorption. It's just like how do you say definition to understand how to do a math. Okay, if I ask you to calculate, you just figure out these numbers and tell the difference. Okay, that's the idea here, folks. Other than that, there's not much in there. Now, this is important. GFR. How do you measure if somebody's kidney is functioning properly or not? We always go for GFR, glomerular filtration rate. I want you guys to think glomerular filtration rate is the same as cardiac output, but different organ. How do we check the heart function? By checking how much cardiac output. Does that make sense, folks? Same thing. So how do you define cardiac output? How much blood comes out of the heart per minute? Same thing in the kidney. How much blood you filter per minute? That's called GFR. GFR is how much blood you filter per minute. It's always go for per minute, folks. Okay, that's the idea. So it's similar to GFR and cardiac output, similar definition, folks. Okay. Now, different books has a different number. For example, this guy says the normal GFR is 100 ml per minute. If you open the Guyton Physiology, they say 125. Not a big difference, okay? It's all within the range. I like the 100 because it's easy to do math, okay? Now, normal GFR is 100 ml per minute. For 1 minute, you filter 100 ml. So for 10 minutes, 1 liter. Is that clear, folks? For 10 minutes, 1 liter. For 60 minutes, 6 liter. So 1 hour we filter 6 liter times 24. How much is that? Who's good at math? That's like, how much we could say? About more than 130 liters, isn't it, folks? Do we urinate 130 liters a day? No. right? We'll be living in the bathroom if that's the case. So we never excrete that much. So what does that tells you? Majority of the filtered urines are reabsorbed. Is that clear, folks? Right? Normally people urinate, let's say about 1 liter approximately a day, 1 or 2 if they drink more water, right? Out of 130 liter approximately, we are only excreting 1 liter. So you could almost say 95% of the filtrate urine is reabsorbed. Is that clear, folks? So that's important. Majority of them are reabsorbed, okay? So normal GFR is 100 ml per minute. So is everybody clear with that? Okay. Now, how do we identify when a patient comes, how is their GFR, right? Now, we don't go and do a specific GFR test. There is, but it's very expensive and very time consuming. So the first thing what we do when I want to know what's patient's GFR, we measure creatinine clearance. Creatinine clearance. Creatinine clearance is an approximate measure of GFR. So if I measure the creatinine clearance, it tells you almost approximate, not precise, approximate. Why do we call it approximate? Because it slightly overestimates GFR because creatinine is moderately secreted also. So what does that tells you? So let's say if a patient has, I'm making this up, 300 creatinine in the urine, I would only consider 250 because the other 50 is secreted. It's not a true measure. Does that make sense, folks? But if a patient come to me, as long as creatinine clearance within the normal range, I know the patient's kidney is functioning good. Is everybody clear, folks? So that's creatinine clearance. Just to tell you, we studied in biochemistry, creatine becomes creatinine. You eat creatine, kidney gives you creatinine. Is that clear, folks? All right. So now, let's say a patient comes to me, and let's say the patient has diabetes, because we know long-term complication of diabetes type 2 is kidney problem, isn't it, folks? So we keep measuring kidney function. The patient comes to me, I'm checking creatinine clearance. If the creatinine clearance comes back within normal range, I have no problem. Even though they are slightly overestimated, but they are within the range, so it tells you it's normal. Is everybody clear, folks? So as long as creatinine is within the normal range, I have no issue. I'm okay with it. But if I come and if I see abnormal creatinine number, it's not within the normal range, that worries me because now the creatinine is not within the normal range. Now is the time to do precise GFR test because now creatinine has become abnormal. Does that make sense, folks? Then I'm going to send the patient to a nephrologist and they're going to go into the lab. They're going to do this test, what we call inulin test. Inulin is a chemical we inject on a patient. They do not produce. We inject. We can use that to calculate GFR. It gives you precise number. Why? Because it is freely filtered, is neither reabsorbed nor secreted. So if I infuse inulin, all the inulin has to come out at the same time, similar time. So that tells you whether your GFR is good or not. Is everybody clear, folks? So we do not send everybody to do inulin. One is very expensive. Number two, you don't need it. So who goes to inulin? Who has abnormal creatinine clearance. Is everybody clear, folks? So if you see somebody, if they're doing inulin, would you want to ask, is your creatinine clearance normal? No. You should already know it's abnormal. That's why they are doing the inulin test, right? That means there is something here, folks, okay? So that's that. So that's the idea. So that's creatinine clearance and inulin. Okay. So everybody clear, folks?
Dr. Roy, can you have other conditions where you can have a decreased GFR, but a normal creatinine, or do they always go together?
No, they always go together because when they have a decreased GFR, that means they are not filtering creatinine.
Okay.
Because whenever they see the GFR, right, glomerulus filtration rate, they are mainly filtering BUN and creatinine. These are the two things. So whatever happens in GFR indirectly will affect creatinine. Yeah.
Thank you.
Okay, so that's the idea, folks. Now remember, creatinine can be measured in the blood and the urine. Here we are talking about urine. How much comes out of the urine. okay? Because you could measure in the blood after a seizure, they will have increased creatinine in the blood because they broke down the muscle. That doesn't mean there's a problem in the kidney. We need to know how much they excrete in the urine. Does that make sense, folks? That's the idea, okay? So careful, that's a part. That's glomerular filtration rate. Is everybody clear with that, folks? Yeah. Next terminology. Renal blood flow autoregulation, right? Because kidney is an important organ, there's an autoregulation is programmed, folks, okay? Now, the autoregulation, if you see autoregulatory mechanism that help maintain a constant renal blood flow and GFR to protect the kidney from rapid increase or decrease in perfusion. Now, if you see, I repeat again, kidney is one of the most important organs, so the blood flow has to be steady at all times. So your body has auto mechanisms that do that, folks, okay? Now, because otherwise it can cause renal injury or decrease glomerular filtrations and stuff, folks. That's important. So how do we maintain that auto-regulation? There's one called myogenic, okay? That's myogenic. Increase arterial pressure. It can stretch the afferent arteriole, which makes sense. When the pressure increases, it will stretch. Mechanical activation of vascular smooth muscle. Vasoconstriction of afferent arteriole that can decrease renal plasma flow. So that's one of the way they reduce the renal plasma flow. Okay, because when do they have to reduce? There could be a situation, more blood is going to the kidney than what they require. So they have to kind of control it. So they control by constriction of afferent arteriole. You see, at the end of the day, afferent arteriole is the one that determines how much blood enter the kidney. Is everybody clear, folks? All right. On the other hand, tubuloglomerulus, right? So that means inside the glomerulus, increased sodium chloride or subtonic, hypertonic fluid filtrate can sense, okay? So they can sense and they can also cause afferent arterial constriction, folks, okay? There's a two mechanism. So the best way to remember here, your AFF, afferent arteriole, determines how much blood enter the kidney glomerulus. Is everybody clear, folks? That's all it is, folks, okay? All right. Now, next terminology, effective renal plasma flow. That means how much blood effectively going into the kidney. That's all it is. Now look at this here. It shows, right? You administer, everything goes and comes. That's effective renal plasma flow. So if I want to know if somebody has a good blood flow to the kidney, I could do a test we call para-aminohipparic acid test, okay? So we inject again PAH. PAH, between filtration and secretion, there is nearly 100% excretion of that. Now look at that, 100% excretion that enter the kidney. So what does that mean? We have to go into the renal artery. So let's say this is a patient renal artery. So you have instruments. We will go to renal artery. At the entrance of renal artery, we will inject the PAH. So we will inject a certain amount of PAH. Okay, let's say, for example, for hypothetical purpose, 50 ml. If I inject a 50 ml in the PAH in the renal artery, it has a timing, let's say 10 hours. 10 hours is probably more. Let's say, make it simple, 3 hours. If I inject 50 ml of PAH, in 3 hours, I should get the whole 50 in the urine. If I inject, and because these are lab pre-formed, so we know if I inject in the renal artery, within 3 hours, I should be able to collect all 100% of PAH. What if I only collect 80%, 70%? What does that tell you? There is an obstruction to the blood flow inside the kidney. I'll give you a good example. Renal artery stenosis. If you have a renal artery stenosis, what happened? The PAH is not entering all of them. They are slowing down. Does that make sense, folks? So that's the idea. So to calculate effective renal plasma flow, the timing is a key, folks. When you give within that time, all the PAH has to come out. Is that clear, folks? That's what they are showing here. You filter, you secrete, 100% has to come out. Okay, so again, remember, these are only done in people who has already an abnormal suspect with the kidney function, folks. Okay, now you don't have to memorize the equation. You don't need to know. Next, look at this. 20 to 25% of the cardiac output goes to the kidney. Again, they are repeating because this is important. Okay. Effective renal plasma flow, underestimate true renal plasma flow slightly, folks. Okay, they are slightly, but still we could measure that effective renal plasma flow. So that's effective renal plasma flow. Okay, make sure you guys write it down. Renal artery stenosis as a good example to have a decreased one so you can understand when you review it. So anytime effective renal plasma flow decreases, there is a problem for the blood to enter the glomerulus. That's all it is. Okay. Now, whatever we studied so far, it is for your understanding most of the time, okay, to understand. But from now, this chart, I say 5-star, 100% minimum one question in this, folks. Minimum one question, okay? So we have to really understand because that chart can cover so many diseases here, folks. Let's see here 1 second. Okay, now let's go here. Before we start, one more terminology we need to introduce: filtration fraction. Okay, filtration fraction. I'll make it easier, but let's see what it is. Filtration fraction normally is about 20%. You see, it's in the percentage. How do we calculate? GFR divided by RPF. How much you are filtering divided by renal plasma flow. Okay, that's how you calculate. But the best way to think, the way I go, I don't miss a question. You know how I say, let's go back to cardio. What did we talk about in the cardio? Cardiac output and ejection fraction. They both goes in the same direction, isn't it, folks? If a patient has increased cardiac output, you will have increased ejection fraction. What's the difference? This is measuring per minute. This is per fraction. Is that clear, folks? This is amount and this is also percentage, isn't it, folks? Same thing in the kidney. If you want to keep it simple, GFR and filtration fraction, they goes together. Okay, GFR and filtration fraction goes together. There's only one exception. They don't. I'll talk about that in a moment. Okay, so other than that, they are both proportional to each other, folks. So you don't need to confuse here. Okay, GFR and filtration fraction goes together, folks. Now, with that information, let's understand. Okay, important. We don't want any pathology. First, we need to learn physiology. Now, so when we talk about afferent arteriole, there's a special prostaglandins. There's a special prostaglandins in the afferent arteriole. What they do, they vasodilate those arteriole. So they are making vasodilation. I want you guys to tell me, if you dilate the blood vessel, what happened to the blood flow? Of course, the quantity is going to increase, right? That's why they say RPF is increased. RPF means renal plasma flow, or you could say renal blood flow is the same thing. Okay, so that's renal plasma flow, folks. Whenever you dilate the afferent arteriole, you are bringing in more blood. If you bring more blood, you would have more filtration. Is everybody clear, folks? More blood you bring in, more filtration. Simple. Now look at this. When renal plasma flow and GFR, they goes on the same direction. When they go in the same direction, the equation don't change. So it's a constant filtration fraction. Okay, so the filtration fraction is constant because in the same direction, folks. That's something you have to understand and memorize it. So that's normal. Is everybody clear here? So this is important. Now always remember, the blood that comes inside the kidney, not only to get filtered, okay, I know you are bringing in waste material to be filtered, but they are also bringing fresh oxygen. Do you guys agree? This is artery, right? Artery means fresh oxygen coming from heart. Oxygen coming. Now think about it, folks. How do you think the tubules get oxygen? This is an epithelial cell. This is an epithelial cell. Inside you have urine. Urine don't have oxygen. So who gives oxygen? Peritubular capillaries give oxygen to these tissues, the tubules. How do that oxygen comes? It's actually the oxygen that entered inside. The oxygen that comes to filter. That blood has oxygen and also the substance to be filtered. Is everybody clear, folks? So can I tell the blood that enter the kidney is so important because they are the one who's going to give oxygen to the entire kidney? So they are the one who's giving. All right. Now, so that's normal physiology. Are we clear, folks? What the prostaglandin does? Okay. How many people heard taking too much too much NSAID can shut down your kidney? You heard at least NSAID is bad for your kidney, right? All right. Let's understand what it does. When you take NSAID so much regularly, what it does, it constricts the afferent arteriole. It constricts the afferent arteriole. How does it constrict? They inhibit prostaglandin. NSAID inhibit the prostaglandin. If you inhibit the prostaglandin, your renal plasma flow is decreased. Is everybody clear, folks? If your renal plasma flow is decreased, then your GFR is also decreased. Because why? Less blood coming in, less filtration. Is everybody clear, folks? What happened to filtration fraction? They both goes in the same direction, so they are constant. Is that clear, folks? As long as they go in the same direction, they are constant. So that's the effect of constriction, okay? That's the effect of NSAID, but that's not really bad. Of course, decrease in GFR is bad. Decrease in GFR is bad, but more than that, now I want you guys to tell me, if I constrict the afferent arteriole, are you bringing in enough oxygen into the glomerulus? No. If you have a less oxygen, can you give it to these tubules? No. So what happened to these tubules? Tubules will have hypoxia, ischemia, infarction, and necrosis. Does that make sense, folks? So it happens in the tubules and it happens in acutely. What do we call that? Acute tubular necrosis. That's that disease. ATN. Everybody think acute tubular necrosis is difficult. It's not. It's one of the easiest disease. Acute tubular necrosis happens acutely. Your tubules are going through necrosis because you are not bringing enough oxygen to the kidney. Is everybody clear, folks? So that's why when you take NSAID, now you know it's not bad for your kidney. It's basically, it can cause acute tubular necrosis. How can you prevent that? Well, don't take NSAID. But if you have to take it, what do? Drink a lot of water with that. Because when you increase the fluid intake, it's vasodilate and push more fluid into the kidney. So it can help a little bit. But down the line, you will have some effect. But remember that, again, they have to take so much for a longer period of time. So, before people said it could be, 10 years, so you have to take it. I take about 350 ibuprofen a year. I've been doing it for 10 years. My kidney is still functioning good, so it's more than 10 years, right? All right. I'm ready, my open ticket to China if I need one. All right. So that's NSAID, folks, okay? So now you guys know what happened. So whatever we just studied, it's right here. Afferent arteriolar constriction. So now you should know who constrict. When they constrict, this is your first change. Write the numbers next to it. First change is decrease in renal plasma flow. That causes decrease in GFR. Therefore, filtration fraction is constant. Is everybody clear, folks? Now, that not only give you afferent arteriolar constriction, that disease that can give you acute tubular necrosis also. Is everybody clear, folks? We will talk about acute tubular necrosis when we do the pathologies. It's one of the most important topic for step 100% one question, but we'll talk about it because we need to know about cast and stuff. Okay, so that's number.
Is it safe to say that any medications that vasoconstrict the afferent cause tubular necrosis?
It's will not cause, but higher risk to cause. Use that way. And then remember, it's all about, so any medication you causes, it reduces the blood flow, but it involves how long they are taking and what's their body level, different people. So the best way to say, they are at risk of necrotian if they take it, right? In the US, we have to be careful with the wording, otherwise they will file a lawsuit, right? You have to. All right. Okay. Now that's afferent arteriole. Are we crystal clear with that? All right. Now let's continue. Let me clean up this. All right. Now let's see here. Now, efferent arteriole. So let's see what happens in efferent arteriole. We have angiotensin 2 come. What angiotensin 2 does, it constricts efferent arteriole. Angiotensin 2 constrict efferent arteriole. The first thing to learn here, renin system only works on the EFF. It has nothing to do with AFF. Saying renin works on AFF, it's a criminal offense. You cannot say that. It's only EFF, folks, okay? It works only on EFF. It only works on EFF. What does it do? It constricts EFF. Now let's see the logics behind here. If this is the EFF, I'm constricting here, narrowed, for example, okay, just one segment. Now, when I am constricting, folks, follow me here in the book. If the opening is narrowed, what happened to the pressure proximal to that? The pressure is high inside, isn't it, folks? The pressure is high. I'm just writing here. The pressure is so high because we are causing a traffic jam. Nothing can get out. Does that make sense, folks? When the pressure is high inside the capillary, they will push everything down. Is everybody clear, folks? Because the pressure inside the blood vessel is so high, so they can increase the filtration. Is everybody clear, folks? So you should know that increases GFR. Does everybody agree? That's because blood is backing up, the pressure is high, folks. Now, the same pressure is going to back up. So it's more pressure inside the glomerulus. Do you think a new blood can come inside? No, it's a traffic jam. It backs up. So that tells you decrease renal plasma flow. Decrease renal plasma flow. Is everybody clear, folks? Decrease renal plasma flow. So whenever you constrict efferent arteriole, it backs up everything. Not only backs up, but also increases the pressure. Is everybody clear, folks? Now you have decreased RPF, increased GFR. If I ask you the filtration fraction, you actually have to do the math. But the best way, when the direction is opposite, stick to GFR. Is that clear, folks? Whatever the side GFR, filtration fraction the same way. Okay, this is important, folks, okay? Because anything that backs up the pressure, so it has its own good and it also has its own bad, okay? That's the idea. Did everybody understand the normal physiology here? Okay, so constricting efferent arteriole is good at certain circumstances. Like when you are dropping in blood pressure, certain things is good. But should you have 24/7? No. Having it 24/7, this effect is pathology. Having this effect, like think about it. If you secrete aldosterone, you're going to do that, isn't it, folks? Aldosterone will do that, right? Because renin stimulates aldosterone. Now think about it. When do we secrete renin? Renin we secrete in the human body when the blood pressure is low. Once your blood pressure is back to normal, then we don't secrete, then this effect is done. So you should know efferent arteriolar constriction, it's happening only when you need it. It is not a continuous effect. Is everybody clear, folks? When you have a continuous effect of this is pathology. A good example I want to talk about is diabetes, not insipidus, diabetes mellitus. Diabetes mellitus gives you continuous effect of efferent arteriolar constriction. Okay, write it down. Diabetes mellitus gives you continuous effect of efferent arteriolar constriction. How? They have this non-enzymatic glycation and they deposit material in the efferent arteriole. So they deposit stuff here. Once you deposit there, it's going to be there permanently. Does that make sense, folks? It's not going to be in the morning and evening only. No, the deposit is there 24/7. Okay. Now, when that deposit is there 24/7, what's going to happen? The pressure inside the capillaries are going to be so high permanently, and it's going to push and increase GFR. Now we see increased GFR. That's we understood. But this is way high GFR. They're pushing. Like for example, in my drawing, try to understand this. Let's clean up this. So in my drawing, the problem with the diabetes is this. There's a glycosylation like this. Okay, that's too much, completely blocked. So let's say here is a constriction effect. That's a diabetic effect. So the blood can only go a little bit this way. So the pressure is high here. So when the pressure is high, what they do? They try to push everything down. Does that make sense, folks? When they try to push everything down, first thing that happens is loss of charge. The first thing that happens is loss of charge, then I see albumin. So when the diabetes is doing that, so what's up? The first change happens in diabetes, we talked in endocrine. In the kidney, I was very specific. The actual first change that happens in the kidney with the diabetes is mesangial expansion. But we cannot measure that. But we say the first change that happens in the kidney that we could measure is increased GFR, if you remember. We wrote this and highlighted this. Now it should make sense. When you have a diabetes, why you have increased GFR. So everybody clear, folks? So people with diabetes have increased GFR. That increase in GFR is hitting so hard on the basement membrane, damaging the basement membrane, and the first thing after increasing GFR, we have albumin in the urine. Is everybody clear, folks? So what's the actual second change? Selective albuminuria. If you go to endocrine, we wrote that too. First increase in albumin, increase in GFR, second increase in albumin. Is everybody clear, folks? Then the damage keep happening. Now we lost the size. Then we lost the second, we lose the size barrier. Then we have global proteinuria. All the protein is coming out. That means your kidney is done. Is everybody clear, folks? You understand the big picture? How diabetes affects the kidney. I literally covered diabetic nephropathy, 1 nephrotic syndrome here. So that saves 2 minutes tomorrow morning. Okay. So that's a nephrotic syndrome. First change increases GFR, but causes charge barrier loss and then the size barrier. Is everybody clear, folks? So when people have diabetes and affect the kidney, you see slowly one by one. You're not going to see today increasing GFR, tomorrow protein. No. From increased GFR, it will take a couple of months to see albumin. From albumin, a couple of months to see protein. If you do something in the meantime, you could slow down the progression. Is that clear, folks? Are you guys following me? So that's the diabetic effect. Now let's go back here. Now, what can I do here? The only thing I can do to reduce GFR. What's the problem with increasing GFR? That's the problem here. What can I do to reduce this? I have vasodilate the efferent arteriole. If I vasodilate the efferent arteriole, the pressure will reduce a little bit inside. The damage won't be like that. Is that clear, folks? How can I do that? We give gas inhibitor. Now you know why we call ACE inhibitor as renoprotective in diabetes. Is that clear, folks? When people have diabetes, even if they don't have high blood pressure, you ACE inhibitor, so the kidney can get protected. Is that clear, folks? Because when people are patients on ACE inhibitor, there is no section dilated, so the pressure doesn't build that much. So everybody clear, folks? That's the effect of ACE inhibitor. ACE inhibitor causes arterial dilation. Okay, that's what it does. Anybody understand what we discussed also? Okay.
I just want to clarify one thing that anonymous glycation happens where in the epithelial cells or
It happens in the epithelium of the different arteriole.
okay, thank you.
Yeah. Now remember, endothelium is basically a specialized epithelial cell. Okay. So but the diabetic non-enzymatic glycation is a part of blood vessel problem, not glomerular problem. Okay. It's part of the non-arterial.
But that's what causes the constriction or like blockage, right?
That's basically the non-enzymatic glycation gives the appearance of constriction.
Okay.
And that is that's the initiate problem. Right. So what is the best way? If somebody has diabetes, the best way to control the glucose, so you don't get the non-enzymatic glycation. But once you get the non-enzymatic glycation, controlling glucose wouldn't be anything. You already formed the atherosclerosis. So at that point, only thing is ACE inhibitor. Is that clear, folks? So one is prevention, one is prevention.
The prevention is ACE inhibitor and then
No. I didn't say that. So prevention is control the blood sugar before you develop the constriction. That means from the day one when the patient diagnosed diabetes, have to maintain the blood sugar level properly.
and this is basically acts only on the fat arteriole.
Yeah. And then if the patient they have about one has this effect, control the blood sugar is important, but it wouldn't cure that problem. At that point, the only thing can be so dilated for an arterial is ACE inhibitor. Because the damage is already done. Is that clear, folks? All right. So now, if you go back, if you run arterial constriction, right? If you run arterial constriction, I could say that diabetes mellitus is a good example. The exam, that's what they would say. What happened to diabetes mellitus? RPFA, you should know where the problem, right? So here, this is the first problem. Increases GFR because of arterial constriction. That causes decrease in plasma flow. Which makes sense. Now look at it. When you have a diabetes, you are damaging the kidney, but you cannot bring enough blood oxygen to the kidney also. Is that clear, folks? So it's a complication so much. Right? And of course, when the arrow is opposite, filtration fraction, we're going to keep it with GFR, same direction. So it's okay. So the
ACE inhibitors were called the up-finding of the constriction, right?
Yeah, it's basically it gives you the vasodilation temporarily. That's it. Now keep in mind, ACE inhibitor will never cure the problem because the atherosclerosis is already there. What ACE inhibitor is doing, slowing your progression of the disease. So if somebody's going to have renal failure in 10 years, with ACE inhibitor you push it to 15 years. Is that clear, folks? But at the end, you will still have renal failure. It slow down the progression. It will never cure the whole thing. Does that make sense, folks? Because once you have a non-enzymatic glycation, you cannot do anything. The only way to cure it is to get a new kidney. Does that make sense, folks? That's the idea. So ACE inhibitor slows down the progression of the disease. We'll talk about this in the nephrotic syndrome tomorrow a little bit more, but that's the idea. So that's peripheral arterial constriction effect. Is everybody clear, folks? So that's perfect. Now let's go to the different one now. Okay, now some easy ones. Let's assume I have increased plasma protein. If I have increased oncotic protein, so that means my oncotic protein in the capillary is increased. Okay, That's oncotic protein in the capillary. What did we say about oncotic protein? They pull towards them, they keep it with them, isn't it, folks? I want you guys to tell me, if you have more protein in the blood vessel, what happened to the filtration here? The filtration is decreased because the protein likes to keep the fluid with them. They don't like to let it go. So anytime you have increased plasma protein, GFR is decreased. Okay, GFR is decreased because they keep the fluid with them, because that's what protein does. They keep the substance and they pull towards them. So they decrease the GFR. Now keep in mind, folks, this is where students go wrong. See, the blood flow is like a train. Okay, what does that mean? When it comes to glomerulus, whatever gets filtered, it filters, and the blood flow keeps continuing. It doesn't slow down. The only way to slow down is to block here or here. Does that make sense, folks? That means increased plasma protein doesn't affect the renal plasma flow because it doesn't slow down the flow. It does not slow down the flow. And this is your filtration fraction because it goes with GFR. It goes with GFR. Okay, so that's increase in plasma protein. Is everybody clear, folks? If you know that, you know the opposite. What happens if you have decreased plasma protein? All the fluid is going to go increase GFR. Increase GFR. Okay. Decreased plasma protein means they don't have enough protein to hold onto it, so everything goes. Again, it doesn't affect the renal plasma flow. Filtration fraction goes with GFR. Is everybody clear, folks? You guys are writing this number 1, number 2 next to, right? So that's important to understand when you review where the problem starts. So that's the most common one. If you need an example for increased plasma protein, a good example, I would say, people take OCP, estrogen, all these things can do that. Decreased plasma protein, liver failure, liver cirrhosis, because most of the proteins are produced in your liver. Is that clear, folks? All right. So they take care of this. Okay. Now let's go for constriction of the ureter. Look at this here, folks. This is interesting also. Patient has a completely blocked ureter for kidney stone, whatever. That means, so assume, even though this is not a ureter, just assume this is the ureter because continuation of the tubules is ureter, isn't it, folks? So assume I have a huge stone here. Can the urine go down? No, urine backs up. So the urine is going to back up. The urine pressure in the glomerulus will be higher than the capillary. Is that clear, folks? And in this diagram, if you see here, if the pressure, if this pressure, folks, okay, if the urine pressure is higher, they will not let the fluid to come down. Agree, folks? If the urine pressure is high, fluid cannot come down. So I could tell GFR is going to be decreased. Is that clear, folks? Now look at that. Whenever there's a constriction of the ureter, GFR is decreased. That's the first change. GFR is decreased. It doesn't affect the renal plasma flow. Blood will keep flowing, folks, okay? So that's that. And then, of course, filtration fraction is going to go with GFR. You see, it's easy. You don't have to do math. Just go with GFR. The only time you need to worry, when they're both in the same direction, no change, constant. So does everybody understand the constriction of ureter? Okay. Now keep in mind, when I'm talking about kidney stone, this happens only the affected kidney. The opposite side is functioning properly. Is that clear, folks? So people also miss that. If I have a kidney stone on my right kidney, I would see that changes only on my right kidney, not on the left kidney. So where do you have to have a problem if both kidney has to be affected? After joining both ureter in the urinary bladder or urethral obstruction. If I tell I have a stone that came all the way down to urethra, that urethral obstruction will affect both kidney. Does that make sense, folks? Or if it is a male, BPH, a good example. So it's you need to know the problem is one kidney or two. Okay. Last one is always an atypical exception is there, right? So that's your dehydration. before you look at it, where is the problem in dehydration? It's not in the kidney. In dehydration, the primary problem is loss of fluid, loss of fluid. Loss of fluid, because dehydration causes loss of fluid. Does that make sense, folks? When you lose a fluid, your intravascular fluids are lost, so the blood that comes to kidney is reduced. Is everybody clear, folks? Now look at this. They put 2 arrows, okay? So very important. They put 2 arrows. That means a very little blood is coming to the kidney. If you have very little blood coming to the kidney, what happened to GFR? That will also be decreased. You see that, folks? But this is where the challenge. Is GFR and RPF decreased equally? They are not equal. Therefore, the equation changes. Filtration fraction is opposite because they are not equally in the same direction. Remember that numerator, denominator, if they are not equal, it changes the ratio, isn't it, folks? So that's one option, dehydration. So the dehydration, you should know the problem is not in the kidney. The problem is in the body, losing fluid. Is that clear, folks?
Can you explain in words why, if you lose fluid, you lose blood?
Because when you say fluid, see, when I'm dehydrating, I'm losing body fluid. Fluid is part of your plasma. Your blood has fluid. It just is because it looks red color is because of the red blood cell. If I remove the red blood cell, your blood will look like a clear fluid. Is that clear, folks? All right. That's the idea. That's dehydration. So because you guys asked, now I'm going to ask you a question back to you guys. Dehydration gives you polycythemia. What type of polycythemia? Type it up, everybody. Dehydration gives you very interesting polycythemia. Don't go for Control F, go for answer. Don't search for the answer. Well, guys, there's only 4 types of polycythemia we studied. Which one is this? Abby, come on. Come on, folks. It's the first one on the page. I hope we could tell that to USMLE like that. We know it, it's on the first. It is the first one. Which one is that? Relative polycythemia. Okay. Relative polycythemia. Because that's what actually not real polycythemia, because you lose the fluid, it makes the blood density high, right? So that's that. So how do you differentiate appropriate and inappropriate? There's only one difference. Appropriate is you have hypoxemia. Because of that, your body produces more erythropoietin. Inappropriate means you have a cancer that secretes ectopic erythropoietin that produces it, right? So make sure after the class today, you review that one section, folks. It takes 2 minutes to review. It's okay, but when you review, it will come on a recollection. Okay, so that's this section. Is everybody clear, folks? All right, go take a break and come back.